this?
Help me.
If so, you've come to the right place. Dr. Perkins is here to help you. With tips and explanations that will not just help you learn the information, but master it for years to come. Alright guys, and welcome back. Today we're going to be talking about metoprolol, also known as low pressure. So a couple of things about this name. When you see olol, it's telling you that it is a beta blocker. Now it's not telling you whether it's a beta selective or beta non-selective. It's just telling you it's a beta blocker. More on beta selective and non-selective later. Next thing you want to know is low pressure, right? Low for low blood pressure. Alright, and that's going to be one of the indications or reasons to take this pill. So as I said earlier, low pressure or metoprolol is used to lower high blood pressure. So it's used for hypertension, it's used for angina pectoris, so you're walking and get this crushing chest pain. Alright, we're going to treat that with low pressure. Alright, and it's going to be used in heart attacks. These are the indications. Alright, now we have off-label uses. Once again, these are non-FDA approved uses. So one of the big things we use this for is migraine prevention. So if I'm having headaches that are migraines, I'm having them 5 times a week. If I take this, I might only have a migraine once a week. Or, instead of it being a level 10, when I do get my migraine, it's only level 5. Anxiety. So one of the big things about this medication is it blocks stress receptors. And so if I'm blocking those stress receptors, I'm not going to feel as anxious. And, I'm not going to get this tremor when I get nervous. So mechanism of action. How does this stuff work? Well, one of the big things to remember is this is going to work on the beta receptors. Now, what are the beta receptors? So remember how epinephrine and norepinephrine, right? We're going to fight or flight, right? We're getting ready to run, move, and everything else. And so what happens is we're releasing the epinephrine and norepinephrine throughout our body. Well, in order for them to work, they have to hit receptors. And so they're going to hit the beta receptors. Now we have one heart and 2 lungs. And so beta 1 is going to be cardioselective. It's mainly just going to work on the heart receptors. Beta 2 is going to work on the lungs. Well, metoprolol is a beta selective, right? It's going to work on my one heart. And so what that's going to do, instead of my heart being like this, the heart's going to slow down. And so because it's slowing down, it doesn't need as much blood flow, so I'm going to get less chest pain. Alright, so that's how it's going to work on angina. Because I'm slowing down my heart rate. Alright, guess what? I'm not pumping as much blood into my body. And so my blood pressure is going to drop. And so that's how we're going to treat high blood pressure. Last but not least, I can use this in somebody that's had a heart attack, right? And so what happens is you have a heart attack, you got this chest pain, your heart's pounding because you're very scared, you're dying and everything else. And so that's putting more work on my heart. Well, my heart can beat slower. Man, out of nowhere, my heart doesn't have to need as much blood flow. And as a result, that's going to help with increasing my chance of survival. Because we're bringing down that blood pressure, we're bringing down the work on the heart, and so less heart muscle is going to die, which means better long-term survival. So how is this stuff getting into your body? Well, most of the time you're taking it by mouth, right? And the reason being is it's very easy, very cheap, and so it's going to work very nicely. Now, we can do it IV. So let's say you're in the hospital, you just had your heart attack, right? I don't want to give you this stuff. I have to wait hours to find out how well you deal with it. And now it's very hard to stop giving you more, right? Once I take it by mouth, you're pretty much in for the duration. Well, what happens if I give you 5 milligrams IV, I can see how you're responding to it. It's like, I don't like kind of where this is headed, but I'm not quite sure if that's because he had a heart attack or if that's the medication. Alright, let's give him his next 5 milligram dose. Okay, yeah, things are definitely getting worse here. So that was the medication, and he's not getting any more. Right, and so that's what they're checking you for. They're going to give you 15 milligrams of metoprolol to see how you respond to it before they actually switch you to an oral dose. But that's in emergency settings. In non-emergency settings, right, we might start you low and work you up. All right, now one of the big things is there's going to be a taper here. over 1 to 2 weeks, pretty much with getting the medication in and with getting the medication out. So why the taper? Alright guys, so why is there a taper? So just imagine you're with Dr. Perkins here, and we're looking at a heart cell. And so what you can see is you got 5 beta receptors. And these beta receptors have epinephrine and norepinephrine bound to them. Right, so 4 out of 5 have epinephrine and norepinephrine bound to them. And so it tells the heart beat harder. It also tells the heart beat faster. And so this is stopping our heart rate from going too low and making sure our heart pumps enough blood so our body can function. So what happens when you take medication? Alright, so here's metoprolol, our green boxes right here. And I'm blocking some receptors here. So now, instead of having 4 active receptors, I only got 1. Right, because I blocked all the other ones that would have been active. So that's going to slow down the heart rate, and it's also going to make the heart not beat as hard. And that's what's going to drop my blood pressure. So problem solved, right? Just give me 25 milligrams, so I'll be good for a long time. Well, not so fast. So the body says, whoa, okay, wait a minute here. I must not have enough beta receptors, or, you know, the body for whatever reason isn't producing enough adrenaline. So I'm gonna up the number of receptors. And so you can see the body like doubled the number of beta receptors. And so now the activity is like a level 3. And so now what happened? My heart rate's gone faster. My heart is squeezing harder, and so I'm moving more blood from the veins to the arteries. It wasn't as bad as what it was before, but it's not as slow as what it was when I first started the medication, right? I've actually developed tolerance to this medicine. It's not going to do what it used to do for me because my body's adjusted. Alright, so now what do? Well, we up the dose. So we double the level of metoprolol. So you can see I got a lot more green boxes. And so I'm going to block a lot more of these receptors. And so now I'm back down to that level 1, right? And so my heart is beating slower. It's not beating quite as hard. And so I'm not moving as much blood from the veins to the arteries. And so my blood pressure is under control. Alright, so what's going to happen if this guy goes to Walmart and he takes his blood pressure and he gets a reading of 120/8? He's saying, woo, yo, it worked. It worked. Going for a walk 5 minutes a day cured my high blood pressure. Right? He's not thinking, well, look, I'm taking medicine every day. That's why my blood pressure is under control. But you'll be amazed how many patients will do that. Anyways, what happens? Well, remember a couple slides ago, all right, he only had 5 receptors and 4 of them were filled. And so he had 4 active receptors causing him to have a blood pressure of, let's say, 150 over 100. Well, now, because his body's adjusted and everything else, he has 10 receptors. And the metoprolol is going to get out of his system a lot faster than his body can adjust. And so he has 10 receptors that are ready, willing, and able to pick up the adrenaline. Alright, and so now, out of nowhere, he doesn't have 4 active beta receptors. He has 8 active beta receptors. So his blood pressure is going to have a new high score, right? And so let's say as before, he had a blood pressure of 150/100. Now, because he stopped taking his medicine, all of a sudden, his blood pressure is going to be, we'll say 180/120. He's like, what the heck? It's never been that high. And so, yeah, we don't taper. We don't stop all of a sudden, right? We got to gradually back off the dose. That way he doesn't have a heart attack or stroke because his body is not used to having a blood pressure that high. So what are some side effects of taking this drug? Well, remember the whole point of these beta receptors was to make your heart beat fast enough and hard enough to move enough blood from the veins to the arteries for your body to work. So if we shut down how much blood your heart's able to pump out, you're going to feel tired. You're like, man, I'm just so tired. Right? As a matter of fact, that can actually be considered depression, right? If you're, hey Bob, you want to go to the park? No. I just need to take a nap, guys, right? It's going to look like depression. You can also have dizziness because, once again, I'm not getting enough blood flow to my brain, so I say, right? I might even fall asleep. We call that passing out and hurt myself. All right. Other things we have is shortness of breath, right? I'm moving blood from the lungs to the body. And so if my heart is having trouble doing that, I'm not getting enough blood flow, I'm going to get out of breath. Another thing that's going to happen as well is that, metoprolol at low doses is beta selective. Remember, we have one heart, two lungs. But as we up the dose, we start turning off other receptors, particularly the beta 2s. And so what happens, your airway starts closing down right here. And so now I can't breathe as good. And so that's going to cause shortness of breath. All right. Raynaud's phenomena. Alright, so one of the things that can happen is because I start working on those beta 2 receptors, because you're upping my dose, it can cause basically the alpha receptors to just have a heyday. Nobody's fighting them anymore. And so now the arteries can clamp down because they're not getting told to stay open because you blocked that message. Alright, diarrhea. Right? The whole point of the beta receptors is we're kind of slowing down the GI tract because you're trying to run away from the tiger or bear, right? Well, if I'm blocking those receptors that would shut down the GI tract becomes too fast now. And so you can get diarrhea, right? Not so much fun there. All right. Now, some people, they can have allergic reactions with this stuff. So a rash, itching of the skin, right? Because I'm blocking the receptors that normally block me from releasing histamine. Okay, now you do have erectile dysfunction because once again, you're not pumping as much blood out. Erectile function isn't going to work as good. And then you are going to have some degree of insulin resistance. All right, so precautions. This is what you should be thinking. Whoop, 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 right? And so if a person has a history of anaphylaxis, you want to hold off on that. Why? Because they're going to be more reactive to whatever it is that their triggers are. And when you give them rescue medication, it's not going to work as good. Diabetes, their blood sugar, if it bottoms out, they might not have any symptoms. Okay, well, no harm, no foul. Well, no, right? You're not having any symptoms until disaster strikes. And then it's too late. And so with all these other things, right, the big deal is you're more likely for things to go wrong, whether it's dental surgery, heavy machine operator, asthmatic, CHF, myasthenia gravis, hyperthyroidism, liver disease, kidney disease, peripheral artery disease, right? So basically that's like you're walking, you get severe leg pain, stuff like that. Depression or hydrochlorothiazide. So not saying you can't use these medications or use a beta blocker in this situation, but you got to be more careful. Alright, when you think contraindications, you need to think of something like this. Right? These YouTube videos where somebody's doing something crazy like jumping on their car roof, and all of a sudden all four windows in the car explode. And that's when they do the oh no's, right? Think about that when you go to give a beta blocker for one of these conditions, right? You got a person who's allergic to a beta blocker, right? Start the music, oh no, oh no, oh no, 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 right? Don't do that. Not a good idea. All right, they have a second degree AV block. Don't do it. They have severe to moderate to severe CHF, cardiogenic shock, peripheral artery disease, right? All these things is a no-go, right? And here's why, right? The heart's not pumping enough blood to the body. And so when you use a beta blocker in these situations, right, what's happening, first degree AV block, moderate to severe CHF and cardiogenic shock, right, we're going to make it worse. The heart's going to be pumping out less blood. With peripheral artery disease and pheochromocytoma, what the problem is here's your artery, and so what happens is the alpha and beta receptors work on that artery. And so what happens is we shut down the beta receptors, and so we're just left with the alpha receptors, and so that artery is going to clamp down, and you're going to get way less blood flow. So not a good idea here. Alright, so nursing interventions, right? You're going to check the blood sugar. Why? Because your blood sugar may bottom out, and your patient's not going to have any symptoms until disaster strikes. For the heart rate, one of the things you're going to do is you're going to tend to hold the medication if the heart rate is less than 60. Telemetry, what are we looking for? We're looking to see if you have greater than that first degree AV block. So, you're dropping QRSs. If you drop QRSs, no, it's contraindicated here. Blood pressure. The point of this medication is to lower your blood pressure, but if it's too low, we're not doing this. Worsening congestive heart failure. One of the ideas of this medicine is we're going to slow down the heart so it can pump more blood to the body, right? So we're moving more blood to the body. Well, if I slow down the heart rate too much, I actually pump less blood. And so now your CHF is going to get worse. Other symptoms we're looking for: chest pain, shortness of breath, right? These are generally going to go with worsening congestive heart failure. Diarrhea, it can cause diarrhea in some people. Insomnia, they don't fully understand why it causes some people trouble in sleeping. But fatigue, fatigue is definitely going to be a quality of life issue. So what are you going to educate your patient about? You're going to educate them about orthostatic hypertension. Well, what does that mean? You stand up and the room goes black, right? So if Bob over here, he goes to, get his medication or get a swallow across the room, falls down and bonks his head, he could die or end up in the hospital. We don't want that happening. Alright, the other thing that we're going to do is educate them about worsening congestive heart failure. So they're gaining weight, shortness of breath, wake up in the middle of the night gasping for breath, decrease exercise tolerance, right? And so you're just going to be looking for those things. Alright, do not crush XL or ER meds, right? Anything that has some sort of timing component, you don't want to crush it. Why? The whole point of those XL or ER meds is, look, I don't want to take my medicine 4 times a day. This is too much work. I'm going to forget. I can't remember. So what happens is we give you 4 pills wrapped into one. And so now, throughout the day, slowly releasing that medication, right? And that way we're not overdosing. Well, if I crush them, I'm getting all 4 pills at once. And so now I'm overdosed and, right? I fall asleep or I get hurt or whatever, right? That could be a major issue. Alright, alcohol. This is very important with any medications. Alright, how does this work together with alcohol? Half of adults drink. And so if they're drinking alcohol with this, they're way more likely for the blood pressure to bottom out. The other thing that they need to know is do not stop taking these medicines all at once. And the reason being is we talked about this already. As we're blocking more and more receptors, the body is making more and more receptors to compensate. And so when you stop taking it like that, what happens is out of nowhere your blood pressure goes sky high, right? New high score, right? Not a good place to be. And so because your blood pressure is so high, you end up having a heart attack or stroke. Alright, so very big deal there. Do not just stop taking these meds overnight. Alright, so here are your NCLEX style questions. You have a few patients with hypertension who should not have metoprolol prescribed to them. No, more than one patient can be a poor candidate for this medication. Joe has severe leg pain when walking up a hill, but can push a heavily loaded shopping cart at Walmart all day. Susie has severe shortness of breath when laying down flat, doing nothing despite being on maximum medical therapy. Alright, next is we have Peter, who has a PR interval greater than 0.24 seconds. Jasmine, who has headaches that are becoming more common and severe, and often accompanied by severe panic, hypertension, rapid heartbeat, and sweating. And then last but not least, we have Bob with well-controlled diabetes. Alright, so here's the answers. So Joe, he has severe leg pain, but when he holds onto the magical shopping cart at Walmart, he gets all better. Okay, that's not claudication. That's actually pseudoclaudication. And so he does not have peripheral artery disease. He might, but it ain't showing up when he's pushing that shopping cart at Walmart, right? Walmart healed him. Maybe they should charge extra for that. But anyways, what's happening is his spinal cord is the problem. That's pseudoclaudication. That's not a contraindication or even a precaution, to giving these medications. Next, Susie has severe shortness of breath when laying down flat. Okay, look, that's congestive heart failure, right? And so we got to max out on medical therapy. It's contraindicated in moderate to severe CHF. If we're maxed out on medical therapy already, we don't want to get a beta blocker to this person. Alright, Peter has a PR interval greater than 0.24 seconds. Alright, what does that mean? Well, a normal PR interval is 0.12 to 0.20 seconds. So we know Peter has first degree AV block. That's okay, we can give the medication. Now, if he had P-wave, QRS, P-wave, QRS, P-wave, no QRS, right, that would be second degree AV block, right? Longer drop, that's also a second degree AV block. Or if the P-waves and the QRSs are just not corresponding to each other, that would be a third degree AV block. All those, no go, right? Contraindicated. But Peter, okay, because it's only first degree AV block. Alright, next, Jasmine. These headaches, more frequent, more severe, panic attacks, high blood pressure, rapid heart rate, sweating. Alright, what is this? This is a pheochromocytoma, right? And so what's happening is you've got this tumor releasing all these stress hormones. We're not going to give a beta blocker here. And the reason being is, once again, what are we blocking? We're blocking the beta adrenergic receptors. And so remember, you have alpha adrenergic and beta adrenergic. And so if we just block the beta receptors, the alpha receptors will be able to work all by themselves, and those arteries will really clamp down. And they have a heart attack or stroke, so not a good idea. All right, Bob, who has well-controlled type 2 diabetes. All right, that's going to be a precaution. It's not a contraindication. So people that are poor candidates here would be number 2, and it's going to be number 4, right? 2 and 4, no go. The rest of them are going to be fine. The only person that we're going to use a precaution on would actually be Bob, right? But that's who the poor candidates are, is 2 and 4. Alright, so what is the most important teaching point for a beta blocker? Alright, taking a beta blocker may raise your blood sugar, may lower your blood sugar, may raise your cholesterol. You should avoid taking grapefruit juice because it may decrease the absorption of your medication. You should avoid taking orange juice because it enhances the absorption of your medication. Or you should take your blood sugar more often because a beta blocker may mask the effect of low blood sugar. Okay, so the answer is number 6. Why? Well, beta blockers raise your blood sugar, not a major issue. You can change things, fix it. Same idea with the cholesterol. Alright, grapefruit juice, orange juice, you're actually going to get less of the beta blocker into your system. Usually grapefruit juice makes it where you get more of a medication in your system. This is a weirdo thing. Usually what we try to say is, hey, we're just going to avoid grapefruit juice, orange juice altogether. Why? Because we don't want your medication level going like this. And the easiest way to stop that from happening is just stop taking the orange juice or grapefruit juice. Alright, so why number 6? Well, what happens is, let's say you have type 1 diabetes, you're living in 1920, insulin doesn't exist, right? The only insulin that exists is what's made by your pancreas, and you can't get it from anywhere. Alright, what's your life expectancy? Alright, your life expectancy is 2 years. In 2 years, half of type 1 diabetics are dead. In 5 years, 90% are dead, right? Not so good. But what's going to be your problem during those 2 years, 5 years? Your blood sugar being too high, right? So you can have a blood sugar that's really high for 2 years before it kills you, right? Anyways, I'm not saying for your type 1 diabetic, save your money, don't take your insulin. No, that's not good, right? You want your blood sugar under control, right? Especially if you've had type 1 diabetes for more than 2 years, you're living on borrowed time, right? So you gotta take that medication, right? Definitely talk to your doctor about your medication. Don't stop taking it. Anyways, let's look at the flip side where your blood sugar is too low, right? So if your blood sugar is less than 18, what can happen? You can get a flat line on your EKG and you can have permanent brain damage in under 30 minutes. In under 30 minutes. 2 years versus 30 minutes. That's pretty short. They did an experiment with monkeys, and they used high levels of insulin to drop their blood sugar. And they found that they usually got brain damage within 5 to 6 hours. Well, if you're passing out, I don't care if it takes 10 hours. There's a good chance somebody's not going to find you in 10 hours, and now you got permanent brain damage. So, very, very big deal, right? So if you have diabetes and you're on a beta blocker, you gotta check your blood sugar more commonly, because we don't want you getting permanent brain damage because you passed out because you didn't realize your blood sugar was too low.